Welcome back, everybody. I hope you had a good lunch break. Here to kick us off for the afternoon is Dr. Eric Schmidt, who's the chief of our MGB division of Pulmonary and Critical Care Medicine. He'll be talking to us about sepsis. And as always, please put your questions in the chat. We had a great group of questions this morning, so many we didn't get through all of them. So let's keep that going for the afternoon. And thank you so much, Dr. Schmidt, for joining us.
Thank you. So again, I'm Eric Schmidt. I'm a physician scientist at MGH and MGB who's fascinated by sepsis, and I hope to share my fascination with this disease with you today. Let's kick it off by talking about a case. There's a patient, MR. 10 days ago, she was at your institution for a cholecystectomy, and now she shows up with fever and back pain. And she is indeed quite febrile. She's also hypotensive and tachycardic. She looks a little bit lethargic, and she does have flank tenderness upon examination. And your analysis shows frank pyuria. She's actually a difficult stick, and she ends up getting a central line. And her nurse asks you, what kind of intravenous fluids do you want to give her, and how much? Do you give her 30 milliliters per kilogram of lactated ringers as a bolus? Do you give her 30 milliliters per kilogram of normal saline as a bolus? Because you've heard that lactated ringers and normal saline is not really that much different. Do you give her 4% albumin? Because you remember reading somewhere that 4% albumin is specifically beneficial in sepsis. Or do you do both? Do you give her crystalloids, but also give her enough albumin to keep her albumin above 3? Because having a significant oncotic pressure is important for the intravenous fluids to actually have an effect. Well, congratulations. You chose the correct choice, and she does better. Blood pressure comes up a little bit, still a little tachycardic, and her CVP is about 6. Creatinine is 1.3, which is higher than her baseline, and her hemoglobin is 9. What's the next step in her resuscitation? You keep on giving her more fluids, get that CVP higher, greater than 8 millimeters of mercury. Do you actually stop fluids because she's hemodynamically stable and you've read somewhere that excess fluids is a bad thing to have? Or do you give her vancomycin, then cefepime, or cefepime, then vancomycin? Again, you chose correctly, but despite your excellent care, she now is doing worse. She's on 2 pressors. Her urine output's dropping. She's got an anion gap, which I'll just tell you is a lactic acidosis. Creatinine's rising. And somehow, somewhere, an overenthusiastic intern orders a cortisol, which is high. And that overenthusiastic intern also gives a cosentropin test. And that cosentropin test only bumps a little bit. What do you do now? Do you give her hydrocortisone and fludrocortisone because she is adrenally insufficient? Do you adjust your glasses and tell that intern, no, we're going to give her hydrocortisone and fludrocortisone because she is relatively adrenally insufficient? Or do you not care what her adrenal axis is? She's sick. She needs hydrocortisone and fludrocortisone. Or do you say, what's all this fludrocortisone crap? It's basically a pill that is not absorbed. And also, hydrocortisone has mineralocorticoid activity. Why do we care about fludrocortisone in this situation? So this case is designed to highlight key issues that affect our management of sepsis today and also affect our management of sepsis for centuries. And so my goals today are basically to discuss the historical context of medicine's attempt to treat sepsis over 5,000 years, and to discuss a little bit what we've learned and the humility we've gained in trying to manage this common disease. Furthermore, I'm going to talk a little bit about the challenges and one of the most common supportive care therapies we give for sepsis, and that's fluid resuscitation. Let's begin by discussing the historical aspects of sepsis. And sepsis actually dates back to 3000 BC in the time of ancient Egyptians. And they have this term called ukedu. And what is ukedu? Ukedu means, roughly speaking, something disgusting from the intestine, which sounds silly. But it was this concept the ancient Egyptians had that all human disease occurred by some sort of nasty process going on in the intestine. When you think about it, it makes a little bit of sense. If I were to eat an apple, that apple is delicious and nutritious, and it goes throughout my intestinal system, and it comes out as poop. And poop is filthy and causes disease. The ancient Egyptians recognized that. So at some point inside me, something good turned bad. And that biologic putrefaction was thought to be the source of all human disease. And so the ancient Egyptians spent a lot of time trying to clean their colons with honey enemas. Honey actually is bacteriostatic. That's why it doesn't have to go in the fridge. Unfortunately, I don't think honey enemas was really having its intended consequence, but the thought was to prevent that ukedu. Now, the Egyptians realized that not all Ketu had to happen in your intestine, it could actually happen in wounds too. And this goes back to a papyrus from 3000 BC, which is basically a case series of injured soldiers. And the soldiers who had a wound and that wound started to putrefy and smell, they called that rot. When that happened, the soldier would get a fever and would die. And so ancient Egyptian medicine spent a lot of time trying to prevent that rot. They would pack wounds with honey, which again was bacteriostatic, or with liniment soaked with wine. Or if they saw rot, they would try to surgically evacuate it. If we go forward a little bit to the times of ancient Greeks, the Greeks expanded upon this concept. They realized that not all forms of biologic putrefaction are bad, some are good. They called the good forms of biologic degradation pepsis, and Galen described the pus that happened on a granulating wound as a good form of biologic degradation. Another form of pepsis was fermentation, which created alcohol, which was thought to be a good thing. Of course, the counterpart to this good biologic degradation was sepsis, bad biologic degradation. Ancient Romans expanded upon this, and they realized that not all forms of biologic degradation had to happen on a person. They can happen in the environment, like swamps full of nasty, decaying vegetable matter. Ancient Romans spent a lot of time trying to drain swamps to prevent the generation of these small little animals that would cause disease. And in doing so, probably unwittingly, prevented malaria. If we go ahead in time, though, to the dawn of American medicine, the late 1800s, early 1900s, the time of William Osler, people realized that sepsis was not actually biologic degradation. It was infection. It wasn't really even an infection. It was bits and pieces of infection getting off in the blood, floating around, and causing an overreaction. That overreaction would cause vascular injury and death. That's a pretty good concept. You can actually argue over the last 50 years or so, we've only made really incremental progress. We now understand what those bits and pieces of pathogens are. We understand how they're sensed. We understand how that sensing leads to an imbalance of pro and anti-inflammatory factors and how that imbalance conspires to cause organ injury. That organ injury causes death. And today we define sepsis according to something called the Sepsis 3 criteria, which says it's a life-threatening organ dysfunction caused by dysregulated host response to infection. Now, it's important to note we really don't fully exactly know what the regulated response to infection is, but we know that in sepsis that goes wrong. And it's a big problem. The ICON study was this survey across 10 days in ICUs around the world, including industrialized societies and low and middle income countries. And they found that at any given ICU around the world, at any given time, around 30% of patients had sepsis. And of those, about a third would die. And this burden is largely faced in sub-Saharan Africa, where there's a high prevalence of sepsis and also a high case fatality rate. But even in industrial societies, such as the United States, sepsis is a major cause of in-hospital death. And it's been estimated that over half of patients who die in hospitals in the United States die from sepsis. They may have been admitted for treatment of cholecystitis, but they die of sepsis. So this is a major problem. It's been a major problem for centuries, millennia. So how do we treat it? Well, people have really largely focused on this aspect of sepsis pathogenesis, this concept that sepsis causes a so-called cytokine storm that damages organs with an inflammatory organ injury. And this is really an offshoot of a process called danger signaling. This has been proposed and modified over the years. Polly Matzinger is one of the people who's modified it. But the concept is the following, is the bit and piece of a pathogen, something called a pathogen-associated molecular pattern, such as lipopolysaccharide, which is a piece of a gram-negative cell membrane, floats around and is sensed by a pattern receptor. Now, the pattern receptor for LPS is toll-like receptor 4. In German, toll means cool or exciting, so this was an exciting receptor when they discovered it. And this receptor sits on a sentinel cell. When the receptor gets triggered, the cell realizes there's danger around it, and it panics, it pumps out inflammatory cytokines, it calls for help, it raises the alarm. And then neutrophils come in, and neutrophils are basically giant battleships of proteases and other enzymes that come in and obliterate the infection and also obliterate healthy tissue around it, just to be safe. Now, this is an appealing pathway because it's so linear. You can imagine, what if we just cleared the blood of PAMPs? Or what if we just blocked the receptors? Or what if we blocked that cytokine storm? If we could do this, maybe we could prevent those battleships from coming in and damaging healthy tissue. What if we do things that suppress all kinds of it, suppress this entire pathway? Could that be a potential way? to potentially offset or minimize inflammatory organ injury. Well, people have tried to do this without much success. Now, it is possible to clean PAMPs from the blood. I could place a dialysis catheter in somebody and pump via CVVH approach, pump blood through this filter. This removes LPS, also removes those angry battleships, the neutrophils. And the initial study was the UFA study, which was published in JAMA, a small study, really well done, really looked for the precise patients and had a benefit. Although the benefit was modest and it was a relatively small study, and so it really demanded additional validation. And a larger study that was really beautifully done, including a sham group, a group that got a dialysis catheter and dialysis, but just a dummy filter. That study was negative after 446 patients. And this basically killed the company that was funding it and basically kind of put a kibosh on this concept of clearing PAMPs from the blood. What about going downstream? Blocking pattern receptors. If we go a step downstream, maybe we'll have more time to treat. Maybe the reason why the clearing PAMPs in the blood didn't work was because the cat was out of the proverbial bag. Well, there are plenty of good inhibitors of toll-like receptors out there. It's one of the most studied receptors ever. This thing called erytorin. This was studied in almost 2,000 patients. It doesn't work. Didn't improve outcomes. There's another drug called TAC242. This actually works great in animals and great in cell culture. I've used it before to block this receptor. Doesn't seem to do much in humans, however. What if we go downstream then? What if we try to block the inflammatory cytokines? And in the 1990s, this was all the rage. Everyone had their own monoclonal antibody or their own dummy receptor they would use to modify the inflammatory cytokine storm. And this review was from 1998, and it goes through all these different studies that tried to block individual cytokines in sepsis, ranging from studies that were about 2,000 patients all the way to studies from a couple. And every single study, the 95% confidence interval touches the line of identity. It means every single study was negative, no harm, no benefit, probably over $1 billion of money that didn't lead to anything. And these kind of failures basically made sepsis kind of a graveyard for pharma. Pharma didn't want to touch this. Now, people have thought about other things, maybe using corticosteroids in sepsis to squash inflammatory responses altogether. In the 1970s, pulse dose, high dose steroids with immunosuppressive intent were used. Although in the 1980s, trials suggested that they weren't really beneficial. And the reason they weren't really beneficial is that any benefit was offset by harm if you had pockets of infection that were untreated. And so we do not do this anymore. We do not give steroids with immunosuppressive intent. If you recall correctly, in the patient anecdote we started with, we talked about steroids, but those weren't steroids for an immunosuppressive intent. And this is a bit of a detour from our inflammatory cascade paradigm. These are stress dose steroids. These are steroids not designed to immunosuppress, but designed to treat something called relative adrenal insufficiency. And what is that? Adrenal insufficiency is when my adrenals are not working. I have tuberculosis, or I've taken a bunch of prednisone, and my adrenals are all shriveled and are not helping out during sepsis. Relative adrenal insufficiency is very different. Instead of shriveled adrenals, I have heroic adrenals. They are producing tons of cortisol, but they have nothing left to give. And it was observed that those patients with high cortisols that don't stimulate anymore, they have worse mortality. And so the thought was, what if we give those patients additional steroids? And this summary, which I hesitate to give, but it was maybe about 7 years ago, nicely summarized from the website formerly known as Twitter, basically summarizes all the major studies that studied stress dose steroids in sepsis. And you can see in every study, with the exception of the HYPER study, which patients weren't really that sick in the HYPER study, but every other study, stress dose steroids got patients off of pressors faster. And the studies that had the sickest patients, they actually improved their mortality. What's interesting, and this is a theme that comes up over and over again, is humility. Remember, we thought that we were treating relative adrenal insufficiency? It turns out the benefit of stress dose steroids has got nothing to do with relative adrenal insufficiency. It helps everybody, no matter what your adrenal axis is. So we thought we were treating something. We bumbled our way onto an effective therapy. We have no idea really why it works. This is a common theme throughout sepsis. Humility, when we think we've figured out the pathogenesis of the disease, we don't really know quite what's going on. So what steroids should you give? So for years, I would only give hydrocortisone because hydrocortisone is intravenous and it has both mineralocorticoid and glucocorticoid activity. However, it's important to note that the two studies that were positive, the two studies with the sickest patients, actually gave both hydrocortisone and fludrocortisone. And again, I was a skeptic. I thought I'm already getting mineralocorticoid activity. And furthermore, if I have a patient who's that sick, who's on two pressors, and I give them a pill, is it really being absorbed? So it can't be that important. But I think I'm wrong. In 2023, there was a study that was called a pseudo trial. It basically took this huge cohort of patients in the Premier database and was able to kind of match them. So it created basically a predicted trial where they took patients with sepsis who happened to get hydrocortisone plus fludrocortisone versus patients who happened to get hydrocortisone alone. And the patients got both, controlling for all these potential confounders, did better. Furthermore, I was wrong. It actually does get absorbed. This is a pharmacokinetic study of patients in septic shock on pressors, and then I give 50 micrograms daily of fludrocortisone. 3 hours later, the levels go up. If I'm doing 50 BID, right before the second dose, it's already up a little bit and it still goes up. And if I'm doing 50 QID, you can see it stays up, it's up and it stays up. So the pill is actually enough to get levels into the blood. So it actually does work. So I have since these studies, I've started giving fludrocortisone as well as hydrocortisone. Okay, getting back to our paradigm, maybe blocking one individual step in and of itself is not enough. Maybe I need to turn down the volume on everything. And there's ways to do this. Immunonutrition, omega-3 fatty acids, you think those are good? They're actually harmful. They were tested in ARDS, so not purely sepsis, but a lot of septic patients have ARDS. And this study actually suggests that patients who got tube feeds with omega-3 fatty acids were longer on the ventilator, were in the ICU longer, were more likely to have organ failure. And there was a really close trend, almost statistically significant, to worsen mortality in those who got omega-3 fatty acids. You may say, that's weird. I thought omega-3 fatty acids are good. Well, this concept that antioxidants are good is not really true in the ICU. If I give somebody glutamine and antioxidants, it worsens ICU survival. Oxidant signaling exists because evolution wants it to exist. And if I just slam it down, that may not be a good thing. Which leads us to vitamin C. Vitamin C was proposed, really, it kind of had its claim to fame by somebody named Paul Merrick, who has an ICU, and he observed, first of all, in around 30 patients in his ICU, they had roughly a 40% mortality that was predicted by Apache 4, and they ended up having a roughly 40% mortality. And he implemented a combination therapy, hydrocortisone, as we talked about, vitamin C, which is a potent antioxidant, and then thiamine, in part because it actually may mitigate vitamin C toxicity. And then the next 30 or so patients he saw, the mortality was dramatically less. And I want to emphasize dramatically less. A 30% absolute risk reduction. That means you need to treat roughly 3 patients to save 1 life. That's unheard of in medicine. The problem with this study is it's a before and after study, which is at high risk of bias. And so this really demanded follow-up randomized controlled trials, which unfortunately did not show this benefit. The vitamin study compared vitamin C, hydrocortisone, and thiamine versus hydrocortisone alone, because you know hydrocortisone may have benefit, probably plus fludrocortisone. And what they found was there was no difference. In fact, the intervention group, the triple therapy group, trended towards worse survival. Similarly negative results were seen in 2 other studies that were published in 2020 and 2021. Furthermore, vitamin C by itself actually is harmful. This was the Lovett study, and patients who got treated with vitamin C had a higher risk of death or persistent organ dysfunction at 28 days. And this matches what we know from the previous study about the deleterious effects of antioxidants in the ICU. Remember, oxidative stress is a physiologic concept. Maybe it gets too high in certain disease states, but exists potentially for a reason. If you block it altogether, you could have bad effects. So we're left with this kind of uncomfortable reality where this stepwise process exists, it's manipulatable, but doesn't seem to help patients. And it makes you wonder, are we missing the boat altogether? Should we instead of focusing on the host, maybe we should focus on blocking the pathogen. After all, sepsis is a very complex host-pathogen interaction. So what about treating infection? Does that help sepsis? Well, it does. And it does based in part upon retrospective studies like this one. This study's been referenced a gazillion times. But basically, it was a retrospective study that estimated that if you delayed antibiotic initiation for every hour after hypotension onset, mortality goes up by 7.6%. And that 1 hour window has basically led societies such as the Surviving Sepsis campaign to say you have to give antibiotics within the first hour of sepsis diagnosis. And this is actually easier said than done. You really need a pharmacist in the ER, you need a pyxis in the ER. You need to be thoughtful about what antibiotic you give. Someone shows up to your ER with a UTI, that's probably gram-negative. Somebody shows up with a skin and soft tissue infection, it's probably gram-positive. And you want to add that first antibiotic going in that's most likely to get the bug that it's affecting. The problem with all this stuff is it's really tough to prospectively test this. I can't choose one person out there to be early antibiotics and then randomize another person to get late antibiotics. That would be unethical. But people try to tackle this via clever ways, like randomizing people to early antibiotics or very early antibiotics. And that was done in the unfortunately named Fantasy trial, which was 25 regional ambulance services in the Netherlands. And they basically took any patient in the ambulance who they thought had infection, and they randomized them to saline or ceftriaxone. And there's some arguments about the effectiveness of randomization, but we'll take this study on its face. And the study actually did enroll quite a few patients with sepsis. Back then, non-severe sepsis, we would just call infection now. Today, we call severe sepsis, and septic shock, we still call septic shock. So in today's sepsis 3 criteria, over 60% of this population would really meet our sepsis criteria. And of those patients, super early antibiotics didn't really do anything, and not in any subgroup. It didn't really seem like decreasing or making the antibiotics even earlier had much of an effect. And it does make some sense when you think about it, because you don't know how long the person's been sick at home. That noise of the variability and how long a person's already been sick at home may not make a small change in antibiotics all that impactful early on. What we do know is that overexuberant use of antibiotics is harmful. We all know about C. diff, but also declaring war on your anaerobic microbiome is not a good thing either. Animal studies, if you wipe out anaerobic bacteria from the colon and then you give that animal lung injury, that animal does worse. Humans who have ventilator-associated pneumonia, if they got anti-anaerobic antimicrobial coverage in the past, they do a lot worse if they have ventilator-associated pneumonia, even when controlling for other confounders. So your anaerobes in your gut microbiome are actually helpful for you to be resilient to pulmonary insults. So,
Great.
Heck of a time to have an update. So basically, if you've been paying attention to this, first of all, sorry for the update. Second of all, we have this challenge where the ancient Egyptians would apply honey and wine to injuries to prevent rot. And today, our best therapy is to give antibiotics before sepsis progresses. And maybe we give steroids to the sickest. This is 5,000 years. And what have we really accomplished in 5,000 years? Remember, I'm a sepsis investigator. Like my parents were not doctors, and they say, Eric, what are you studying? I say, I study this disease. And they said, have you cured it yet? And I'm like, no, people have studied for 5,000 years. And they look at me like, what have they done? What has their son accomplished? But for me, I'm super enthusiastic about ability to change this disease. And here's the reason why. Let's do a thought experiment. Let's imagine somebody has cancer and that patient goes to their doctor and says, okay, what kind of cancer do I have? The doctor would never say, oh, don't worry about it. Doesn't matter what kind of cancer you have. We treat all cancer the same. That wouldn't work. That'd be silly. We try to figure out what kind of cancer it is. We do molecular phenotyping of that cancer. We design a therapy targeting that kind of cancer. Sepsis, however, every single study I've just talked about took all septic patients and it treated them with the similar sepsis drug. It treated sepsis as a homogeneous disease state, and every single study was negative. And the reason why I think all these studies have failed is that sepsis is not a homogeneous disease state. There's probably different kinds of sepsis. Maybe there's pneumonia-induced sepsis or non-pulmonary sepsis. We should try to figure out different endotypes of sepsis in order to be able to treat it properly and to create an individualized precision medicine approach. And there's some evidence this actually will work. You may have heard of activated protein C or Zigris or drogecogen alpha. This came onto the scene in the Prowess study in New England Journal in 2001. And it was shown that patients who got 96 hours of activated protein C had improved survival compared to placebo. There was a risk of bleeding, and the benefit was only seen in patients who were less sick. In fact, the FDA only approved it in the benefits were only seen in patients who were more sick. And the FDA therefore only approved it in patients who were more sick. And follow-up studies started to question the benefit of this. There was no benefit at all in the less sick, and there was a high risk of bleeding in the real world. And the European Union actually demanded they repeat the study, the Prowess shock study, and that repeated study showed no benefit. Its activated protein C was pulled from the market. So why did activated protein C no longer work? What was it about this study that it didn't work? And so is it possible that not all forms of sepsis respond to activated protein C, but some might? And this, we can learn a lot from the ARDS field. The ARDS field recognizes there's two forms of ARDS. There's a hypoinflammatory, which is still inflamed. There's a hyperinflammatory, which is more inflamed. Hyperinflammatory has a worse mortality, has a different kind of blood milieu. Hypoinflammatory, better mortality, different kind of blood milieu. But they respond differently to different therapies. And these ARDS studies that were negative were probably negative because one group did better and one group did worse, and they canceled each other out. So what's interesting is in Prowess shock, we saw exactly that. Basically, patients who were hypoinflammatory did worse when they got activated protein C. On the other end of the spectrum, patients who were hyperinflammatory with sepsis did better when they got activated protein C. So the reason why Prowess shock failed was not because it doesn't work in sepsis, but it works in only certain kinds of sepsis. And if we can identify those certain kinds at the bedside, we have a chance to mechanistically target this disease. Now, until then, we are left with supportive therapies. And in the last 14 minutes, I want to basically be able to discuss what we know about fluid resuscitation, one of the most common forms of supportive therapies we give in sepsis. We'll talk about what kind of fluid resuscitation we give, and we'll talk about how much is too much. Let's talk about the kind of fluid resuscitation we typically give. One of the most dominant studies in critical care literature is the SAFE study. This is a study that basically compared saline versus 4% albumin for fluid resuscitation. All kinds of fluid needs were treated with saline or 4% albumin. There was no difference in outcomes. Only thing that was of interest is patients with traumatic brain injury did worse with saline. Did worse with albumin. So they did better with saline. There was this interesting trend towards improved outcomes in sepsis, but the difference between this was thought to basically just be chance. And the authors actually discouraged people from overinterpreting these findings. Now, to my amusement, several years later, the authors actually did publish this, and they wanted to study this subgroup more. And I think they kind of overcalled it. They looked at the sepsis cohort, which there was no benefit from albumin, and they took the sepsis subgroup of the SAFE study, which did have benefit, and they did a subgroup of the subgroup, and that was septic patients with complete records. Now, why is that? I don't know. But that subgroup of a subgroup, suddenly now albumin had a benefit. And it was a significant benefit. It dropped the risk of mortality by 29%, and it was statistically significant. And so acolytes of albumin point to this and say, albumin, we should use it, particularly in sepsis. And expert guidelines have kind of thrown their hands up in the air and said, okay, whatever. Fine, you can give it if you need to, but give crystalloid first. So albumin you're allowed to give, but you typically are supposed to give it after you've exhausted crystalloid as an initial therapy. Again, reminding you, if you're going to give albumin, don't give it to patients with a traumatic brain injury, because there was actually a harm signal in the original SAFE study. And this traumatic brain injury subgroup pops up over and over again. We'll come back to that in a little bit. Now, what about giving albumin for a different reason? What if we give crystalloid, but we also give albumin to keep the serum albumin greater than 3 milligrams per deciliter? And that's what the Albios study did. And indeed, it kept one group with the albumin levels that were high. And the thought was you increase oncotic tone, and albumin ferries about endothelial protective mediators. And so did this have any kind of benefit? No, didn't do anything. So albumin by itself, not really a very clear benefit unless you look at a subgroup of a subgroup. Albumin as a supplemental agent, also not much of a benefit. So we're left with crystalloids. There's two kinds of crystalloids. There's normal saline, which can cause a non-gap acidosis, and there's so-called balanced fluids like plasma light or lactated ringers. And the real foundational study that supported the use of balanced crystalloids came from Matt Semler's group at Vanderbilt. This is a pragmatic trial. So a pragmatic trial, they don't have to consent each individual patient. They basically randomized ICUs to use what was thought to be equivalent things, saline or balanced crystalloids, and every month the ICUs would switch. So during that month, you go to the Pyxis, you grab basically a blinded bag of fluid, and you didn't know if it was saline or a balanced crystalloid. And they were able to enroll 15,000 patients across Vanderbilt. And they looked at a composite of death and kidney injury. And the reason is that preclinical studies suggest that kidney injury it can be caused potentially by saline. And the study suggested that balanced crystalloids were actually better, and specifically better in the sepsis group. Now, again, these weren't patient-level randomization, it was ICU-level randomization. This benefit has not actually been seen when you try to randomize individual patients. The BASIC study was a huge study that was done in Brazil during COVID, and it looked at two things. It looked at, do you give slow fluids versus fast fluids? When I was a resident, my chief resident would yell at me if I ever gave fluids at 333 milliliters per hour. Joke's on him, it doesn't matter. But if you look at the other aspects of it, balanced crystalloids versus normal saline, 5,000 patients per group. This study was bigger than the SAFE study. Absolutely no difference in outcomes. Similarly, the PLUS trial, which actually was able to show that saline caused a slight acidosis and caused a hyperchloremia. Despite causing the acidosis and hyperchloremia, absolutely no difference in outcomes. Almost looks superimposed, the lines. And so the question is, like, what do I believe? And the answer is, first, you want to give crystalloids. We know that for sure. You can give albumin if there is a large amount of fluids and there's no intracranial injury. Balanced crystalloids may in one study be better, but the effect size is probably small, although you can argue that balanced crystalloids don't cause harm, and even a small benefit over a large number of people may have some sort of positive impact. So I think if you're forced to do one or the other, you would give lactated ringers. The only time you would not give lactated ringers, actually, is in traumatic brain injury. There it is again. Meta-analysis suggested that lactated ringers is also harmful in traumatic brain injury. Someone's got traumatic brain injury, you go with saline. Now, the last topic is how much is too much? And we all know instinctively that if I give people too much fluids, bad things happen. And we have to give people aggressive fluids early on. That's ingrained in us ever since early goal-directed therapy, where the initial resuscitation was 30 milliliters per kilogram of crystalloid. Even though that study has been since disproven, the concept of early aggressive fluid resuscitation echoes throughout things such as the Surviving Sepsis campaign. But there is this concern, what if we overdo it? When do you stop? Because retrospective studies or randomized controlled studies of ARDS suggest that over-enthusiastic fluid resuscitation is associated with longer time on the ventilator. And in some subgroup analyses, people who have fluid overload do worse, which again kind of makes sense. So this was directly tested by something called the CLOVER study, the crystalloid liberal or vasopressor early resuscitation and sepsis study. It's part of the PETAL network, and every PETAL study had to be named after a flower or some sort of plant, so that's why it's called CLOVERs. And this study was published in 2023, and it was basically 1,500 patients who were enrolled in the ER, and it was limited to the first 24 hours. And there was basically this algorithm that was designed in one group to minimize fluids and one group to be more permissive to fluids. The minimized fluids had more pressors, the more permissive group had fewer pressors. And altogether, patients had about 2 liters before they got randomized. And then by the end of the protocol, there was a 2-liter difference. So you saw about a 2-liter separation between groups. And the study was stopped early because it didn't do anything. If you're an optimist, you'll say, look, there was no harm in giving fewer fluids. If you're a pessimist, you say, well, it didn't have any benefit at all. Why do we do this whole study? But you can see it's really interesting. Every single subgroup did not have a benefit. Now, one possible reason why this study did not show benefit, it was limited to the first 24 hours. And what if we try to actually restrict fluids throughout the entire ICU stay? What if we make it annoying to give fluids, like we make antibiotics annoying to give? So if I want to give imipenem, it's a pain in the butt for me to get approval to get imipenem. And so there's a nudge in my brain not to give imipenem. What if we make it, you have to get like a fluid approval pager to give fluids? Nothing that dramatic, but what if you give certain rules that disincentivize giving fluids? Well, this is what this study did, and it was able to actually minimize fluids modestly, but even up to 90 days later, the patients got the restricted fluid group had 723 cc's fewer fluids 90 days later from that protocol during their ICU stay. All right, congratulations. You are 723 cc's fluid less. What does that do? Nothing, not a lot. So the effort to minimize fluid does not translate. Now, noticeably, however, this is a broad population. This is not specifically focused on any individual patient. I just got done telling you that we need to do precision medicine. We need to customize our approach. So maybe we need to find the right patient who will respond to fluids and give that patient specific fluids. And we've been trying to do this for quite some time. In fact, I would say the great white whale in critical care medicine is, are you wet or are you dry? We always pontificate that every couple of years, comes out the best possible way of discerning it. It's important to keep in mind that hemodynamic variables, static hemodynamic variables, are terrible at predicting it. And I always like to point out to my cardiology friends, this study, Machard and colleagues took a bunch of septic patients that were on the ventilator and they had Swan-Ganz catheters in, because of course they did, it was in 2000. And those patients had, first of all, a whole gamut of baseline hemodynamic variables, including a thermodilution cardiac output. Then they got a slug of colloid. Then they remeasured the cardiac output. And those patients whose cardiac output went up were, in retrospect, colloid responsive, or maybe I guess you would say they were dry. Their cardiac output went up and they got fluids. And the question was, okay, what about those baseline variables predicted that response to the colloid bolus? And here it is. This is a receiver operating characteristic curve, which basically judges how good a test is at predicting an outcome. An ideal test goes straight up and straight over. A coin flip is diagonal. Static variables, like right atrial pressure or central venous pressure, are no different than a coin flip. I mean, generations of cardiologists have stared at necks to look at JVP. It doesn't predict if you do better with fluids or not. That's what the data say. Furthermore, wedge is terrible. Wedge lies to you. Wedge is worse than a coin flip if you want to predict if somebody will respond to fluids or not. What does work are dynamic changes. A change in pulse pressure with a tidal volume greater than 10 cc's per kilo. This study came out before low tidal volume ventilation, but the change in intrathoracic pressure, if your IVC is collapsible enough that you see a change in pulse pressure, that suggests you're dry, and that was highly predictive. And not everybody has swans right now, however. But there's a way of actually potentially doing this without having a swan. You can do things like impedance measurements of cardiac output. This is done in the FRESH study, which basically took patients who the clinician thought they might need fluids, put this impedance plethysmography device on to measure cardiac output, and they did a passive leg raise. And patients who got a passive leg raise, which is like that colloid slug I told you about, and their cardiac output went up, those patients were allowed to get more fluids. Patients whose cardiac outputs did not go up, they did not get more fluids. And patients who got this intervention ended up getting less fluids or fewer fluids. They were less likely to need to go on dialysis, and they were less likely to be intubated. Now, this is a huge study, and it's very interesting, but the problem is, I don't know how generalizable it is. They looked at 5,000 patients, they only enrolled 150. And so does this really help your patient or not? Is it too specific? They're trying to do it again, the FRESH 2 study, and we'll see how that study kind of weighs out. So in summary, what I've hoped to do today is tell you a little bit that we've been studying disease for 5,000 years, and a lot of this has been banging our heads into a wall. And we're left with some fundamental treatments, early antibiotics, maybe stress dose steroids. But there's a ton of enthusiasm that maybe now with precision medicine approaches that understand not all sepsis is the same, we can really customize these more mechanistically targeted therapies for the kind of sepsis your patient has. And so I think the next 5 years is going to be a paradigm shift in how we treat sepsis. So exciting. Until then, however, we need to do the best we can to properly support our patients. And despite that, there are still substantial knowledge gaps in what kinds of fluids to give and how much to give. So it's an exciting time to study sepsis. I think we have a great opportunity to help our patients. So back to our patient MR, what kind of fluid do you want to give? I would give lactated ringers. I would not argue if you want to give saline. I don't think the data is all that strong one way. 4% albumin, you're banking upon a subgroup of a subgroup. I don't think that's necessary. And the Albio study said you should not try to replete someone's albumin greater than 3. Thank goodness, otherwise we'd run out of albumin. What we do here, well, CVP greater than 8 is a vestige of early goal-directed therapy. We know that Clover's was a negative study, so you don't really need to be too miserly about fluids. She probably has a UTI. It's probably gram-negative. Get that cefepime fast. And last, despite the fact that for years I've badmouthed fludrocortisone, I think it works. And the fact that she's super sick, I would give her hydrocortisone, fludrocortisone, because it seems to work and it does get indeed absorbed. And with that, I'd like to end. I thank you for your attention today.